So, good evening, everyone. Good evening, everyone. Right. So, welcome to this particular class wherein we will be doing the NIMHANS high yield questions. And let me first tell you what I will be doing in this particular half an hour. I'll be doing some of the image based questions. I'll be also doing, or I'll be also teaching you to solve a clinical based question, and I'll be also doing some of the single liner questions. So it's just a type of a mixed bag of questions related to neurology and which are very high yield questions to your neurology. Next. So to start with the discussion, let me just give you a clinical scenario and as well as an image based question. So the question is as follows. We have a 60-year-old man presenting with the history of memory loss and fatigue. Sorry. And on examination, he has bradykinesia with axial rigidity. Resting tremor is absent and patient has broad-based gait with tendency to fall. MRI was done. And this is the MRI of the individual. All are true about the condition except the options are poor response to levodopa, gaze palsy, pseudobulbar palsy, intracranial hypotension. All of the following are true about the condition except yes, mad for aims. You have answered progressive supranuclear palsy as the diagnosis. But what is the answer in this particular question? All of true about the condition except. Any one of you, please? Very good, mad for aims. The answer is intracranial hypotension. Okay, now first of all, let me take up the discussion of this question. So you see, what exactly is the clinical information which has been given to you? The clinical information is that the individual is having, right, the individual is having a poor response to levodopa with bradykinesia and rigidity. So what does that indicate? What does this indicate? Poor response to levodopa with bradykinesia and rigidity. What does that indicate? Can anyone tell me? Right. So this indicates that the individual is having atypical Parkinsonism. Right. This indicates that the individual is having atypical Parkinsonism. Now, the other point is you take the resting tremors is absent in the individual, which is classical of Parkinson's disease. So resting tremor is absent. So that means the Parkinson's disease is not present in the individual. And this particular individual has a high tendency for the recurrent fall. So what does this particular clinical image or the clinical suggest you of? Tendency to recurrent fall. In this clinical scenario, you have to think of PSP, that is progressive supranuclear palsy, right? Progressive supranuclear gaze palsy. That is what you have to think of. Next, now the MRI, if you see the MRI, it is showing what is called as the hummingbird appearance, right? I'll just give you a better MRI. Yes, so this is your classical hummingbird appearance in this particular disorder, that is progressive supranuclear palsy. Okay, now in this particular clinical scenario of the progressive supranuclear palsy, why does this particular individual will achieve or get this particular hummingbird appearance? Why? Because if you take the midbrain, there is atrophy of the midbrain. Right, there is atrophy of the midbrain, and that atrophied midbrain, I can just show you the marker. The atrophied midbrain that looks like the bird with beak anteriorly, right? The atrophied midbrain will give you an appearance of a bird with beak anteriorly towards your, right, towards your optic chiasma. right, towards your optic chiasma. So in this image, if you see this arrow, okay, so this arrow is pointer towards your optic chiasma. And the very important point is you take the pons. The pons, it is preserved. Preserved pons forms the body of the beak. So if you take this particular body of the beak, this is being formed by preserved pons. And this particular structure of the hummingbird is formed by atrophied midbrain. So the presence of atrophied midbrain and the preserved pons will give you the hummingbird appearance in the MRI. Okay, next. How do you treat these individuals? Let me tell you, these individuals they have poor response to your levodopa, right? They have poor response to levodopa. So going back to the question again, the individual is having memory loss, right, and also fatigue. Bradykinesia is there, axial rigidity is there. So presence of bradykinesia and axial rigidity, right, that will point that the individual is having Parkinsonism. But resting tremors is absent. Tendency to fall repeatedly, that tells that the individual is having atypical Parkinsonism. And MRI shows hummingbird appearance. So definitely the diagnosis is progressive supranuclear palsy, right? So these individuals, they have poor response to levodopa is a correct answer. Now, yes, very good, A1. So now what is the drug you will give in these individuals? We give momentin, and they have gaze palsy. What gaze palsy? Upward gaze palsy. And these individuals, they are also having a type of what is called pseudobulbar palsy, wherein there is upper motor neuron involvement or corticobulbar tract involvement. And these individuals, they will not have intracranial hypotension. Remember this point, these individuals with the progressive supranuclear palsy, they will not have intracranial hypotension. So the question asked is except. So what is your answer now? The answer is intracranial hypotension. Right. So I hope everyone has understood this particular question. Any difficulty in this question? All right. So, right. Now we will move on to the next question. Yes, before going on to the next question, I'll just give you a brief idea what we are doing in this Unacademy platform. So we are providing completely live lectures rather than the recorded lectures. We are providing completely the live lectures. And if you are subscribed to one course, you have unlimited access to all the courses. That is another advantage of this Unacademy platform. And we are also giving you the practice test in which we will be asking you single liner questions, clinical based questions and all. But all these will be available only those students who have subscribed for this particular Unacademy platform. And all that whatever we are teaching in this Unacademy platform, all the courses, you will be getting the notes in the form of PDF format, right? You can download all the courses. And you are having one-to-one mentorship and as well as guidance. You are also having a separate doubt clearing sessions. Separate doubt clearing sessions is the important mark of this Unacademy platform, right? And these are all the courses like what we have in the month of March. We have totally 48 courses related to clinical subjects, 23 courses we have related to paraclinical subjects, 18 courses related to preclinical subjects, 6 courses of batch courses, 5 courses syllabus and practice. So these are the courses which we are having for the month of March. And you subscribe to one course, you are accessible to all the courses. That is the beauty of Unacademy. And those students who are willing to subscribe, you can subscribe 1 month course, 3 months, 6 months, 12 months and 24 months. And accordingly you have the payment slots, right? And those students who want the discount on this particular courses, you can use my code, that is Raj1769, wherein you get 10% discount on your subscription. Okay, so this is to just inform you what courses we are doing on this Unacademy platform. Now, We will move on to one more image based question. Which of the following syndromes is shown below? Weber syndrome, Millard-Gubler syndrome, lateral medullary syndrome, Anton syndrome. Any one of you, please? Weber syndrome. Okay, very good. So, mad for aims, you are really mad for aims, definitely. Right, you are answering absolutely well and good. Now, let me tell you what are the structures which have been gone here. Yes, Nilima, you are also correct. So, you see, this is the green mark what he has put. That means this particular structure is gone. And he has also put a mark on this particular structure. Now, what are these structures? So, this particular structure, can anyone tell me? I have just put it as A. What is this A? What is this particular structure? Right, very good. So that is your third cranial nerve. So whatever I have marked it as A is a third cranial nerve. Now you see, so this is your oculomotor nerve or your third cranial nerve. This is what I have marked it as A. And you see the other structures which have been gone. So the other structures which have been gone, they are involving the crus cerebri. So within the crus cerebri, that is nothing but your cerebral peduncle. What are the structures which have been damaged? That is your corticospinal tract. Corticospinal tract, it is an upper motor neuron. Right? So in this individual, if you see now, you take the corticospinal tract. Corticospinal tract, they cross to the opposite side. Where do they cross? This is actually the structure of what? This is the structure at the level of midbrain. Now, why am I telling that this is the structure at the level of midbrain? Because I am having the third nerve nucleus. Where will be the third nerve nucleus present? The third nerve nucleus is present in the midbrain. So, this structure is basically the cut section of your midbrain. Now, you take this corticospinal tract. The corticospinal tract, it is present on the ipsilateral side at the level of your midbrain. But once this corticospinal tract is descending down at the level of medulla oblongata, it crosses to the opposite side. So that is the reason why if you take in these patients with these structures are gone, third nerve is gone and corticospinal tract is gone, and the corticospinal tract, it will go to the opposite side. So if you take the discussion now, let me discuss all the syndromes which have been given in the question. So first and foremost, you see the Weber syndrome. Now what is your Weber syndrome? Weber syndrome, remember, it is ipsilateral third nerve palsy and contralateral hemiplegia. Why contralateral hemiplegia? Because your corticospinal tract will cross at the level of the medulla oblongata, and that is the reason why they'll have contralateral hemiplegia. So contralateral hemiplegia is because of the involvement of your corticospinal tract. Next, you take the choice B, right? Now what is your choice B? This second option, what you have is your Millard-Gubler syndrome. Now, what will be the features in Millard-Gubler syndrome? Remember, in Millard-Gubler syndrome, you will have ipsilateral 6th and as well as 7th nerve palsy. Along with that, there will be contralateral hemiplegia. But the nerve which has been damaged within the image given to you is the third nerve. So that is the reason why it is nothing but your Weber syndrome. Right? Next, the other third option what has been given to you, that is lateral medullary syndrome. Lateral medullary syndrome, this is also called Wallenberg syndrome. And what is the important vessel which gets affected here in Wallenberg syndrome? Remember, it is your vertebral artery which is affected in Wallenberg syndrome. And most of you might be under the confusion of pica, that is posterior inferior cerebellar artery. But remember, it is the vertebral artery which is most commonly affected, and followed by that, the involvement of your pica, that is posterior inferior cerebellar artery will be involved in the Wallenberg syndrome. After the next to the involvement of your vertebral artery. Now, what will be the features in case of the Wallenberg syndrome? In Wallenberg syndrome, remember, these individuals, they will have ipsilateral involvement of 5th, 7th, 8th, 9th, 10th and as well as 11th cranial nerve. But along with this, these individuals, they will have crossed hemianesthesia. And this crossed hemianesthesia is because of the involvement of spinothalamic tract, which has crossed at the same level of the spine. So in this patient, in the image given to us, third nerve is involved. So it is not your Wallenberg syndrome. Now you take the fourth option. What is your fourth option? That is your Anton syndrome. Now if you take this Anton syndrome, now what is your Anton syndrome? Anton syndrome, the individual will have bilateral occipital, right, bilateral occipital cortex lesions. Now this bilateral occipital cortex lesions will give you gun barrel vision, right, will give you gun barrel vision. That means the narrowed vision. Okay, so this is what is your Anton syndrome. So just to summarize all the syndromes: Weber syndrome, ipsilateral third nerve, contralateral hemiparesis; Millard-Gubler syndrome, ipsilateral 6th and 7th nerve, contralateral hemiparesis; lateral medullary syndrome, ipsilateral 5th, 7th, 8th, 9th, 10th and 11th nerve and crossed hemianesthesia; Anton syndrome, bilateral occipital cortex lesion, and these individuals, they will have gun barrel vision. So if you take this particular point of discussion now, so what will be your answer? The answer will be your Weber syndrome, right? The answer is Weber syndrome. Okay, why? Third nerve is involved and as well as contralateral involvement of your corticospinal tract. Where do you have that? That you have in the crus cerebri. Okay, now, so I hope everyone has understood this question. Yes, Pradeep Reddy, you are correct. Right. So once we have understood this particular question, we will move on to one of the clinical based question. I hope everyone are understanding the session. I just want a small reply from those who are listening to the session so that I can continue further. All right. So moving to the next question. We have a 50-year-old patient presenting with complaints of weakness on the right side and left-sided loss of sensation. On examination, both upper limb and lower limb of the right side has decreased tone, and on right side, Horner syndrome is present. He is having dysarthria and difficulty in swallowing, and he has hemisensory loss on left side of the body with loss of touch, pain and temperature. Which is the cause of symptoms in this patient? The options are right pica, left pica, right middle cerebral artery occlusion. Fourth option, basilar artery occlusion. All right. So, right. Now, what is the, I'll just summarize the clinical scenario in the patient. Summarize the clinical scenario in the patient. He is a 50-year-old patient presenting to you with a history of weakness on the right side and left-sided loss of sensation is there. And what does the examination show? That is decreased tone, right? Examination shows decreased tone, where in the right upper limb and right lower limb, and there is right Horner syndrome also. He is having dysarthria and as well as difficulty in swallowing, and hemisensory loss is there on the opposite side, that is left side. That means if you just analyze this particular clinical scenario, the individual is having, I'll just summarize this individual is having dysarthria and as well as the dysphagia, presence of, right, presence of dysarthria and as well as dysphagia. What does this suggest? This suggests that the individual is having bulbar palsy. Right? This suggests the individual is having bulbar palsy. Next, the individual is having loss of pain and temperature. Loss of pain and temperature. What does this suggest? This suggests the involvement of lateral spinothalamic tract involvement. And the individual is having hypotonia. What does this suggest? Hypotonia in a patient with a stroke. That tells that there is cerebellar involvement. Right? Cerebellar involvement. Okay. Now, summarizing all these, where do you think is the site of lesion? Bulbar palsy, that means medulla should have been gone, right? And that to which particular cranial nerves? Mainly your 9th and 10th cranial nerve. So 9th and 10th cranial nerve are present in which part of the medulla? Lateral part of the medulla. So one picture we have got that lateral part of the medulla has been affected. Then even associated with that there is also involvement of your cerebellum. And associated with that there is also presence of your lateral spinothalamic tract. And if you see the question also tells that the patient is having right-sided Horner syndrome. And there is also spinothalamic tract involvement on the opposite side. So if you just see this exactly is the scenario of the patient. You see, the individual is having ipsilateral Horners. That means right side. Okay, and contralateral loss of sensation. Along with that, the individual is having the involvement of 9th, 10th, 11th cranial nerve. So the entire story goes in favor of lateral medullary syndrome. Now, which sided lateral medullary syndrome? This particular patient is having right-sided lateral medullary syndrome. So if it is a right-sided lateral medullary syndrome, which vessel do you think that it has been occluded? That is your right pica. So this is nothing but your lateral medullary syndrome or Wallenberg syndrome. So to summarize this entire lateral medullary syndrome and Wallenberg syndrome, these are the clinical points. The patient is having the blockage of right pica. That is the reason why the individual is having right-sided weakness in arm and leg. Remember, right-sided weakness in arm and leg, whatever the patient is having, hypotonia. So it is a cerebellar involvement. Right, that is your cerebellar involvement. And right-sided element palsy of your 10th nerve, that is your bulbar palsy. Right, bulbar palsy. Left-sided loss of pain and temperature, that is left-sided spinothalamic tract involvement. So this entire thing gives you a picture that there is right lateral medullary syndrome. And for right lateral medullary syndrome, right pica should have been involved. Okay, right. So I hope you people have understood this particular explanation of this question. Right. So once you have understood this question, we will move on to a single liner question. Yeah. Nimodipine is used in the management of yes. Very good, Matt for Ames, right? Excellent. Yes. All of you are answering this very correctly. But you should know, why do we give nimodipine in patients with a subarachnoid hemorrhage? Yes, Matt for Ames, can you answer me? Why do we give nimodipine in the patients with subarachnoid hemorrhage? Why do you give nimodipine? Yes. Where? Vasospasm where? Nimodipine is given in the treatment of subarachnoid hemorrhage. Okay, so we give this calcium channel blocker. Why? See, in case of subarachnoid hemorrhage, what is the major cause of death? The major cause of death in patients with subarachnoid hemorrhage is due to vasospasm of surrounding vessels. Right, it is due to vasospasm of surrounding vessels, and because of this vasospasm the individual may land up in brain infarction. Right, the individual may land up in brain infarction. Now you want that this vasospasm has to be relieved. For relieving this vasospasm, we give calcium channel blocker, that is nimodipine. But always remember, this nimodipine, it is a double-edged sword. Right? Nimodipine, it is a double-edged sword. What it can cause? It can cause very severe hypotension. Right? It can cause very severe hypotension. Yes, mad for aims. Now what will you give? If the patient is having hypotension, when the individual is started with the calcium channel blocker in a patient with subarachnoid hemorrhage, what will you do? Remember, this particular hypotension, it has to be treated with IV fluids, and along with that vasopressors has to be given. Right? Vasopressors has to be given. And what are these vasopressors used? These vasopressors which are used is norepinephrine or phenylephrine should be given. Right? Norepinephrine or phenylephrine has to be given. Okay, very good. So these are the drugs that has to be given in patients who are having hypotension. So going back to the question, nimodipine is used in the management of your subarachnoid hemorrhage. Why? Mainly to prevent the vasospasm in the surrounding structures, which may cause the death of the individual. Now, I'll just put up a last question for the discussion. Which of the following is the feature of headache due to increase in the intracranial pressure? The options are increase on coughing or sneezing, most commonly present as focal severe acute headache, pulsatile in nature, throbbing in character. Analgesics are very helpful. Any one of you? Yes, who will answer this question? CD. So you mean to say that pulsatile and throbbing character is the feature in case of increased intracranial tension? B and D, most commonly present as focal severe acute headache. Oh my god. Only one has answered correctly, that is Pradeep Reddy. Pradeep Reddy, Ritesh. Yes, you are correct. So the answer is only A. Right? Let me discuss. Let me discuss what will be the features of the headache in case of increased intracranial pressure. What will be the features of headache in case of increased intracranial pressure? First of all, the question gives you pulsating or throbbing nature of headache. That is one of the options is pulsating and the other option is throbbing. Remember, this pulsating or throbbing nature of the headache, it is seen in patients with migraine. Right? It is seen in patients with migraine, not in patients with your increased intracranial pressure. Take this point for me. And in case of increased intracranial pressure, what will be the features? These individuals, they will have non-pulsating headache. Non-pulsating headache. And they have association with nausea and as well as vomiting. Right? Nausea and as well as vomiting. And the other important point is this particular headache of increased intracranial pressure, it is increased by physical activity or maneuvers which increase the intracranial pressure. Now, what are the maneuvers which will increase the intracranial pressure? That includes Valsalva maneuver. That includes coughing. That includes sneezing. These are the maneuvers which will increase the intracranial pressure. So this can cause worsening of the headache, and this particular occurring in attack-like episodes. And the other point is, in case of this raised intracranial pressure, what does the CT scan shows? CT scan shows presence of intracranial space occupying lesions. Right? Next. And this particular headache, whatever is there, it develops or deteriorates in close temporal relation with your hydrocephalus. I'll repeat this point again. this headache, it develops and deteriorates in close temporal relation to the hydrocephalus. That means if there is associated hydrocephalus, the headache will still get worsened. And this particular headache of raised intracranial pressure, it improves within 7 days after surgery. Right? It improves within 7 days after surgery. So these are the points of increased intracranial pressure. Right? Now I'll go back to the question again. So this will increase with coughing and as well as vomiting, because these maneuvers, they will increase the intracranial pressure. Most commonly present as focal is an incorrect. Focal is incorrect. Right? It will be throughout the head where you can have headache. Pulsatile and not throbbing, these are the features of migraine. Analgesics are very helpful is completely an incorrect statement. Right? These individuals, if it is due to intracranial space occupying lesion, the individual has to undergo any particular surgery, right, wherein the individual's headache will be relieved within 7 days following the surgery. So, and yes, Pradeep Reddy, you are correct, the individual will also have signs of papilledema, that is swelling of the optic disc, and that is because of raised intracranial pressure. Right? So this is the discussion on high yield questions on this particular NIMHANS exam. These questions will be useful even for your AIMS and as well as even for your NEET PG, that is postgraduate entrance exams. Right? So lastly, to just tell you about this Unacademy platform, we are giving you a beautiful courses. So those students who have subscribed, they will be getting live plus classes, test series and quiz, and doubt clearing sessions. And finally, those students who want to get subscribed, you can use my code, that is Raj1769, to get 10% discount on your subscription. So I hope that you people have enjoyed this particular session. Yes, Ritesh Raja, you are asking me management of migraine. Let me tell you, the migraine, it can be present as mild, moderate or severe. In case of mild to moderate migraine, we give NSAIDs. But in case of acute severe migraine, the drug of choice is sumatriptan. In acute severe migraine, drug of choice is sumatriptan. Whereas mild to moderate migraine, that can be managed even with your NSAIDs also. Right? So I think I have answered you, Ritesh Raja. Right. So I'll just wind up the session.